I'll be speaking about the anti-HBV potential of PD-1 blockade in chronic infection. Several of the introductory elements to this have been well covered by Adam and by Robert, so I'll do my best not to labour any points. But just to begin, T cells require three signals for complete activation. Signal 1, peptide MHC TCR. Signal 2, co-stimulation to help drive their proliferation and expansion. And signal 3, cytokine support, typically from matured dendritic cells. It goes without saying, I think, that the T cell response in chronic hepatitis B infection is well characterised as being of narrow breadth and poor functionality. T cell exhaustion is a major pathway mediating the impaired response in situ, and this is from improper priming, from chronic antigen exposure, and from progressive co-inhibitory signalling. As T cells are activated, they upregulate a variety of co-inhibitory markers seen on the left-hand side here. And the signalling from these leads to T cell exhaustion characterized by progressive loss of proliferative function, of cytokine production, and an increased susceptibility to apoptosis in situ, which leads eventually to the deletion of, in this case, HBV-specific T cells. And the best characterized and the most clinically or therapeutically relevant at the moment axis of co-inhibition is programmed cell death 1, or PD-1, and its ligands PD-L1 and PD-L2. So PD-1 expression and signaling, it's in the CD28 IGSF family. As I said, it binds PD-L1 and PD-L2. PD-1 is actually important for normal tissue homeostasis. Knockout mice develop severe lupus-like diseases and also a profound cardiomyopathy. PD-1 is actually also important for normal T cell memory formation, so it's expressed relatively rapidly after T cell activation. And in antigen-specific T cell PD-1 knockouts in mice form a normal effector compartment after stimulation, but they fail to contract and form a lasting memory compartment. As I say, PD-1 is expressed on activated and on memory T cells rapidly after stimulation, and it locates in the immunological synapse, and it acts as a rheostat to alter both TCR-mediated and CD28-mediated, so signal 1 and signal 2 mediated signaling. And it does this by recruiting circumology phosphatases, SHP1 and SHP2, and these dephosphorylate the sequelae to TCR and to CD28 signaling from protein kinase C, from PI3K to affect T cell proliferation, and to act as a rheostat to alter the strength of TCR signaling to allow T cells to rest as memory cells. PD-1 is typically thought of as being a conventional T cell restricted marker, but it's actually expressed on B cells, as we've heard today, on NK cells under certain conditions, macrophages, and on dendritic cells. And interestingly, it's also expressed on regulatory subsets, both MDSCs that can infiltrate the liver, and on regulatory T cells. And on these cells, PD-1 signaling actually promotes their immunosuppressive function. So it's important to bear in mind that a PD-1, PD-L1 blockade doesn't just promote the activity of conventional T cells, it also inhibits the activity of regulatory subsets, and in that manner it can reprogram an immunosuppressive microenvironment. The regulation of PD-1 is quite complex and multifactorial. It's under transcriptional control by the transcription factors AP1, NFAT, and FOXO1, several promoter binding elements upstream of the gene itself. Its expression can be strongly inhibited by TBET and BLIMP1, which are expressed by healthy effector cells, although BLIMP1 expression is also a characteristic of late-stage exhausted cells. And interestingly, PD-1, the locus, is also under epigenetic control. There are several methylation sites upstream of the gene itself, indicated by these little markers here in this relatively complex diagram. I won't belabor this, but the important takeaway is that in exhausted T cells from chronic TCR stimulation, the locus becomes constitutively demethylated and remains open, and this potentiates ongoing PD-1 expression. Its primary binding partner, PD-L1, is a B7 transmembrane protein. It's expressed in normal stroma and on myeloid cells, and it's an interferon-responsive gene, so type 1 and 2 interferons will upregulate it through the standard JAK-STAT interferon-responsive element pathway. And interestingly, the liver is replete with cells that can express PD-L1, indicated here as B7H1, which is its alternate name, the sinusoidal endothelium, the stellate cells, hepatocytes themselves, particularly after hepatitis B virus infection, local DCs and Kupffer cells, and also infiltrating myeloid-derived suppressor cells. And in this manner, the liver, which is in and of itself a relatively tolerogenic environment, somewhat recapitulates the immunosuppressive environment that we might see in an established solid tumour, which is where PD-1 blockade has typically been used. So as I say, there's a relatively long clinical history now of blockading PD-1 or PD-L1 in solid tumours, and in fact, several therapies have been approved for clinical use as first-line therapy in melanoma and renal cell carcinoma, bladder cancer, and lung cancer. And this is data from some of the seminal studies that indicated the efficacy of, in this case, pembrolizumab, which is an anti-PD-1, and an anti-PD-L1 here in melanoma and in non-small cell lung cancer. What's interesting, or what's analogous between hepatitis B viral cells and the tumour-infiltrating lymphocytes that migrate into solid tumours like melanoma is that the microenvironment is similarly immunosuppressive, and the cancer-specific T cells, these typically recognise mutant neoantigens or cancer germline antigens, are similarly exhausted. So they express several of the functional markers that we've just heard Robert describe in detail in the same way that hepatitis B virus-specific cells do. Typically, even in the more successful melanoma studies, only a minority of patients will effectively respond and have a complete response to anti-PD-1 therapy. But what's important, and it's mostly indicated by this green line here, which is the top dose of pembro used in this study, is the therapeutic tail and the flattening. And what you can see is that typically when PD-1 works to reinvigorate T-cell responses in situ, those responses can be curative, and subsequent studies have tracked these patients out over nearly 5 years now, and typically if you exhibit a complete response at 2 years, that response will be durable out to 5 years. And this is in stage 4 melanoma, which is one of the most challenging environments for checkpoint blockade. Moving back into the hepatitis B space, this has been investigated in the woodchuck hepatitis virus model, which, like human hepatitis, is a chronic infection characterized by poor T-cell response and a high viral load. So several studies have indicated that an in vivo intervention with anti-PD-L1 is safe and well tolerated by these animals, and that, as we've heard today, serum surface antigen levels predict response in a negative correlation fashion. If you take T cells, WHV specific T cells out of the woodchucks, they can be reinvigorated or have their effector function restored ex vivo by anti-PD-L1 blockade. And this important study showed that with nucleoside analog therapy and a therapeutic DNA vaccination in combination with anti-PD-L1, both T and B cell function were enhanced in a subset of animals, leading to the suppression of viral replication, to seroconversion and viral clearance and functional cures, like I say, in a subset of animals, which recapitulates a human situation relatively well. Several groups have also investigated T-cell exhaustion in chronic hepatitis B patients, and so it's relatively well established now that hepatitis B specific T cells uniformly express PD-1, although, as Robert just showed, the remainder of their phenotypic classification can be highly heterogeneous. And typically we see a lower level of CD28 expression on T cells, which indicates a greater level of differentiation. Specific T cells are typically heavily enriched in the liver, which suggests that they are being trapped in there, and this is probably to do with their requirement for constant low-grade antigen stimulation for their survival. And several other studies in both murine models and looking at chronic hepatitis B patients have indicated that PD-L1 blockade ex vivo, so isolating cells from liver biopsy or from PBMC, can restore T-cell proliferation outside the body. And interestingly, the efficacy of ex vivo blockade is best predicted by T-cell differentiation status, and in this particular study, this was measured by retention of CD27 expression at TNF family co-stimulatory receptor. And several studies have profiled the phenotypic nature of the exhausted T cells and shown that there's a hierarchy of inhibitory receptor expression. There's several listed down here, PD-1, KLRG1, 2B4, etc. And typically, whenever these are profiled, PD-1 is the most constitutively expressed on hepatitis B virus-specific cells, and blockade of PD-1 is the greatest, alleviates the exhausted phenotype and allows proliferation to the greatest extent. This schema here is by no means uniform across the studies. There's also, people have shown that this TIM3 checkpoint blockade marker can be highly enriched in hepatitis B virus-specific T cells, and that blockade of this also has important functional consequences, but that's a little outside the scope of my talk. And finally, just before I get into some primary data, there is now some accumulating evidence in trials that have utilized anti-PD-1, this is nivolumab, in hepatocellular carcinoma associated with hepatitis B virus infection, that in a certain subset of patients, you can see a profound diminishment of surface antigen subsequent to treatment. So I'll spend the remainder of my time discussing aspects of a phase 1 clinical trial that we've been involved with, utilizing nivolumab plus or minus the therapeutic vaccine GS4774. This is a multivalent vaccine expressing several hepatitis B viral antigens in a recombinant yeast setting. Nivolumab is a monoclonal against anti-PD-1. It's been approved for use in several solid cancers. It's human IgG4, so it doesn't fix complement, and it has a half-life of 12 to 20 days, clearance depending on dose and body size. And just the background context, this vaccine, GS4774, has been shown to be immunogenic in hepatitis B patients, so it can boost ex vivo ELISpot responses. But even under those circumstances, it lacks therapeutic efficacy, so it's likely that even as the T-cell responses are boosted, whether in number or in functionality, they still remain impaired in situ. Just to briefly describe the study design, there's a dose escalation element to this from 0.1 to 0.3 mg per kg just to assess safety. And then cohorts were dosed either with nivolumab alone or nivolumab in combination with 2 doses of this therapeutic vaccine. Receptor occupancy, so that is the binding of nivolumab to PD-1 on cells in the blood, was assessed, as was the surface antigen load at 12 and 24 weeks. And it's interesting to note that the doses used here are only 1/10 of the doses that are approved for clinical use in melanoma. So this was a low dose and relatively safe trial. Using flow cytometry, multiparametric flow cytometry, to profile PD-1 expression on pan T cells. So this is not hepatitis B virus specific T cells, this is pan T cells in the circulating blood. You can see that PD-1 is primarily, its expression is restricted to T cells themselves, and in fact its expression is restricted to the memory compartment of T cells, and there's a hierarchy of expression with effector memory expressing more typically than temora or central memory cells. Investigating the duration and extent of occupancy by nivolumab, this is after a single infusion, we saw a universal occupancy window out to 43 days in all subjects tested, and there's very little change in the extent of occupancy. And then by day 85, you start to see differential occupancy, and this will be based on different clearance rates, just typically due to body size. And interestingly, comparing 0.1 and 0.3 mg per kg dosage across this uniform occupancy window, there was no significant difference noticed. This administration of nivolumab was well tolerated, and there were no immune-mediated adverse effects noted, which is important because one of the risks in checkpoint blockade therapy, particularly in cancers using higher doses, has been immune-mediated adverse effects, but none were seen here. Investigating surface antigen changes from baseline, 2 and 3 of 22 patients exhibited a greater than a half-log decline in surface antigen at weeks 12 and 24. And interestingly, I've also included here the maximum loss seen in all patients. And what's notable here is that there are some patients who exhibit a loss, or a reasonable loss of surface antigen, which then and then we see the titers rise back to normal levels. And this is indicative of a partial response So you have early T-cell control and then that fails, which probably indicates that there are more complex mechanisms of regulation than simply just PD-1 mediated exhaustion going on. Interestingly, almost all patients exhibited some loss of surface antigen titer, circulating surface antigen titer, and this was typically more pronounced in the therapeutic vaccine plus Nivo arm, but the greatest responses, I'm bearing the lead a little bit here, were observed in this patient in the nivolumab-only arm, and I'll just detail a little bit more about this particular case study. So this donor started off with relatively high surface antigen titer, which remained stable to about 4 weeks post-nivolumab infusion, at which point the patient exhibited a relatively heavy ALT flare. And subsequent to that, surface antigen titers progressively declined to effectively undetectable levels over the course of another 8 weeks as the ALT flare resolved. And interestingly, tracking, in this case, core antigen-specific T-cell responses from baseline through to week 24, it was noticeable that after resolution of infection, a much greater number of interferon gamma-producing core antigen-specific cells could be observed in the blood. So these are circulating cells, not intrahepatic. What's interesting is that delving deeper into the phenotypic subsetting of the T cells circulating in the blood, this increased number doesn't actually represent an expansion of antigen-specific cells. Rather, what this represents is a profound lymphocyte subset redistribution. So if you look tracking across time at baseline weeks 4, 12, and 24, and assessing the naive central memory, effector memory, TEMRA, and CD57, or effector compartment of the peripheral T cells, there was in both the CD4 and the CD8 compartment a profound increase in circulating effector memory, and in this case CD8 positive, CD57 positive T cells. And what this suggests is that these cells of this phenotype have been released from the liver after presumably previously being trapped there by chemokine cues. And it's this recompartmentalization that actually increases the apparent number of interferon gamma producing hepatitis B specific cells. And this release from the liver chimes with previous studies that have suggested that the appearance of PD-1 high or BIM high T cells in the periphery post-resolution of infection is a marker of hepatitis B virus clearance. So just to summarize briefly the results of this trial, PD-1 receptor occupancy is maintained for up to 85 days following a single dose of nivolumab without evidence of autoimmune-mediated adverse effects. So this is a safe, well-tolerated treatment and relatively prolonged. Most patients treated with nivolumab exhibited some decline in surface antigen by week 12, and one patient experienced complete and sustained surface antigen loss, also underwent seroconversion, and remains disease-free 29 months post-administration, and this patient has effectively been cured and has come off oral antivirals. So just briefly, before I finish, I'll touch on some future directions in this field. So at the moment, anti-PD-1 stands as a possible curative agent in hepatitis B, although the responses observed in our study was really only 1 in 20. Alternatives to supplement anti-PD-1 therapy include targeting similarly anti-PD-L1 with monoclonals, small interfering RNA technology to knock out PD-L1 in target cells, although this would only ever be transient, and as an alternative to antibody-mediated blockade, small molecule inhibitors of PD-1 and or PD-L1, and these may have a more predictable half-life and a more controllable clearance rate. Finally, several studies have shown, both in a cancer setting and in a chronic viral disease setting, that combination checkpoint blockade therapies can be synergistic with anti-PD-1. And this involves either targeting multiple checkpoints, so blockading TIM3 or CD244, or utilizing a checkpoint blockade of PD-1 in combination with an agonistic target, so stimulating T-cell responses at the same time as you prevent their inhibition. The tumor necrosis factor receptor CD1 through 7 is a good target for this, for which a clinical antibody exists. And just finally, given that there is some knowledge about epitope-specific hepatitis V virus cells, hepatitis B infection, chronic hep B infection, is a potential candidate for adoptive cell transfer. This is a technique that's often used in cancer. whereby exhausted T cells can be taken from the body, expanded under restorative conditions after being captured either by tetramers or following activation marker-based isolation, subsequent to being stimulated by peptides. And they can be expanded under restorative conditions that modulate their cell phenotype and metabolism before reinfusion. So you can take relatively exhausted T cells and create a healthy library of antigen-specific cells that can go back into the body to exert a more profound effector function. And this can be carried out with agonistic microbeads of clinical grade. The ex vivo expansion allows you to alter the cytokine support, and several studies recently have shown the importance of exposure to interleukin-12 in promoting T-cell effector function and in reprogramming any metabolic defects that they might have accumulated. And similarly, it allows you to apply additional co-stimulatory effects, so agonistic anti-CD137 being a good candidate for this. And I'll just finish with this data unpublished from our lab. This is not from chronic hepatitis B. This is from, these are libraries of tumor-infiltrating lymphocytes that have been excised and grown out from a melanoma sample that came into our lab. And this is tracking the phenotype of the cells after expansion using a particular cytokine cocktail pre and post. And what you can see is that you can expand T cells. I don't have the extent here, but these are typically roughly 100-fold expansions with retention of co-stimulatory markers CD27 and CD28, loss of the effector molecule, exhaustion molecule CD57, and interestingly, a total loss of PD-1 on the expanded libraries, and this can be carried out without loss of epitope breadth and specificity, as measured in this case by responses to CMV and EBV. So I'll leave it there. Again, thank you very much to everyone who contributed to this study, and thank you to the organisers.